So thanks very much. We're really pleased to be able to share our work on improving hospital-to-home transitions. So there was a citizen panel, as you know, and that while some of the panelists identified positive experiences transitioning from hospital to home, most people agreed that hospital-to-home transitions were very stressful as well as risky. They often felt left to their own devices to manage their care and the care of their loved one, to coordinate and navigate the healthcare system. They identified several key areas that contributed to the stress and risks associated with hospital-to-home transitions, such as not having an identified community-based provider to coordinate their transition from hospital to home, or not having enough information regarding what to expect during the transition, both while in hospital and then while at home, and who to contact for help. Other issues were not having a comprehensive assessment prior to and immediately after the transition home. And another challenge was not being engaged in planning their hospital-to-home transition, which meant that they had the limited opportunity to digest information, ask questions, or even to be given options. Next slide. So many older adults have complex health and social needs that make hospital-to-home transitions both complex and risky. Worldwide, more than half of older adults have 2 or more chronic conditions, with a mean or an average of 4 chronic conditions per person. The prevalence rates of this, which is called multimorbidity, are as high as 43% in Canada, 63% in the US, and 67% in the United Kingdom. And we've seen a significant increase in these rates over the last 3 decades. Older adults with multimorbidity, compared to those who do not have multimorbidity, often report lower levels of quality of life. They have higher levels of disability, mortality, as well as burden on caregivers. And when we speak about chronic conditions, we refer to conditions that are both physical and mental in nature. So this includes mental health issues such as Alzheimer's and other dementias and depression. Noteworthy is that of the chronic conditions that coexist amongst individuals with multiple chronic conditions, the most common condition is depression. And we know that older adults who have multiple chronic conditions are 2 to 3 times more likely to have depression compared to those without multimorbidity. And depression is a common and serious problem in its own right, and it's estimated to affect up to 40% of community living older adults. The transition from hospital to home is further complicated not only by the medical, physical conditions that people have, but by the presence of other social and economic disadvantages, such as being financially insecure or socially isolated, or some are geographically isolated and have difficulty accessing services, or live in inadequate and unaffordable housing, or have limited health literacy. Next slide. So hospital-to-home transitions for older adults who have complex health and social needs are often poorly coordinated and fragmented. And this can lead to a number of adverse events, such as serious safety risks for older adults. And this could be related to, for example, medication errors or lack of proper equipment or assistive devices in the home that can increase the risk of falls. There could also be an increase in complications related to the lack of timely follow-up care and support following discharge, or unplanned hospital readmissions or ER visits. And finally, and most importantly, an increased burden not only on older adults, but also increased burden on their family, informal family or friend caregivers. Next slide. So research suggests that transitions that are well planned can enhance continuity and coordination of care for older adults with complex health and social needs who are transitioning from hospital to home, and improve communication among older adults, their family caregivers, and providers. And this can lead to reduction in the length of stay in hospital, reduced hospital readmissions, and increased use of primary care and other community-based services that could help them to prevent health problems. It can reduce the use of unnecessary home care services, as well as premature admission to long-term care homes. And finally, overall, these transitional care interventions can lead to better health outcomes and quality of life. So next, Carrie.
Thanks, Maureen. We know that in Ontario right now there are a number of reforms that are taking place. So we're looking at Ontario Health and the Ontario Health teams. And some of the goals of that work are to, for example, break down some of the silos in the system of care so that there's better communication, better coordination across those different parts of the health and social care systems. Looking at providing more integrated care so that people can understand what their needs are and be able to, access all of the range of services that are needed to best serve those needs. A third issue relates to improving those care transitions. Again, because of the silos that tend to exist and the lack of integration, that's where issues often happen, is when people are transitioning from one system to the other or from one sector to the other. And then finally, there's an emphasis in these reforms on trying to reduce health inequities, because we know that not all individuals experience the same type of care and have access to the same type of care across the province. So the work that we're going to be talking about today was based on an opportunity that we had to seek input on how to improve both the quality as well as the experience of transitions of individuals that are moving from hospital to the community. And specifically, those individuals that are older and have complex health and social needs, as Maureen has described, as well as their caregivers. Next slide, please. So here's an acknowledgement of our partners. So the citizen brief and the citizen panel that it was prepared to inform were funded through the Community Assets Supporting Transitions, otherwise known as the CAS study. And the CAS study received funding from the Ontario SPORE Support Unit, as well as the Labarge Optimal Aging Initiative. The CAS study is also supported by the CIHR Signative Initiative in Community-Based Primary Health Care. The McMaster Health Forum receives both financial and in-kind support from McMaster University. And of course, the disclaimer that the views that are expressed in the evidence brief are the views of the authors and should not be taken to represent the views of the funders. Next slide. So this slide just highlights an overview of the Community Asset Supporting Transitions, or CAS study. So this was an initiative or transitional care program that our research team developed, and it was a nurse-led, community-based program of support. And it focused on assisting older adults that had multiple chronic conditions, so 2 or more chronic conditions and depressive symptoms, when they were trying to transfer or discharge home after a hospital stay. So as mentioned, this initiative or program was led by a registered nurse, and it included both home visits to individuals after they had returned home from hospital and telephone calls. And the goals were to improve the transitions that were made, the care that they received, and try to support both them and their caregivers after they had been discharged, in hopes that that discharge would be successful. There were 5 core features of the program. A significant component had to do with system coordination and navigation. So trying to link the individuals themselves as well as their caregivers to the services and supports that they needed once they were home. A second feature was reviewing medications and reconciling medications so that the individuals were on the medications that were required and the doses that were required. A third component was assessing patients' health and social needs and mental health needs to understand what their unique circumstances were, so that the other aspects of the program could be tailored to best meet both their needs as well as their preferences. A fourth component of the program was working on skill development. So building the individual skills in both problem solving and in coping. Because we know, particularly with individuals that are living with depressive symptoms, that it can be really difficult sometimes to go through these processes and break down problems and try to find the best ways to address those issues. So we had specific training with those with the participants in the study to try to work on developing those skills. And then finally, providing education and coaching to the patients or participants in the study, as well as their family caregivers. And that would be related to their both mental health conditions and physical health conditions, about how to work with other healthcare providers and how to navigate the system. And I think we turn it over to FP.
Thank you, Carrie. So the CAS study then led to this consultation we did, the citizen panel. And the objective of the citizen panel was to seek input from older adults, mostly older adults who have multiple chronic conditions and also complex social needs, and their caregivers about how we could improve hospital to home transitions. So we wanted to get their input on the problem. So we wanted to make sure we understood correctly the challenges to improving hospital to home transitions. We also wanted to get their views on different elements to address the problem. So are there particular strategies that could be helpful to improve hospital to home transitions? And lastly, if we're trying to move forward with any of these options or strategies, what are potential implementation considerations that we need to keep in mind? So what are potential barriers? What are potential windows of opportunities? So that was the overall objective of the citizen panel. So you see here, it's a bit blurry perhaps for you, but it gives you a quick overview of the project. So we ran some preliminary consultation with steering committee members that brought together researchers and other stakeholders and patient partners. We connected with a firm, an online market research firm, to help us to recruit citizens and patients and caregivers from across Ontario. We ran key informant interviews, and also the production of all our documents went through a merit review process to ensure that it was relevant to the context of Ontario, that it was robust in terms of the evidence that was provided, and especially for the citizen panel, we wanted to make sure that it was easily accessible and the information was presented in a way that it could really inform a citizen deliberation. So before the citizen panel, we circulated to the group a citizen brief. So it was a short document that provided details about the problem, potential elements to address the problem, and implementation considerations. We then brought a group of citizens for a face-to-face one-day event. And after that, we summarized their key insights into a panel summary. One activity that was not originally planned is to do a stakeholder dialogue. So sometimes at the McMaster Health Forum, we do both citizen panels and stakeholder dialogues, but originally our plan was just to do a citizen panel. What's interesting is that actually the citizens during the discussion said, well, you should bring together a group of stakeholders from Ontario to address this issue, to come together to deliberate, bring our insights into consideration, and try to find solutions. So we decided to expand the scope of the project, and we'll be convening a stakeholder dialogue in the next few months to address this issue from the stakeholder perspective. And then a lot of outputs from the projects that are made publicly available, and I'll provide you a link to some of these outputs later. So for those of you who may not be familiar with the citizen panel format, it's a mechanisms to bring together a group of citizens and provide them with the opportunity to make informed judgments about addressing a high priority issue. In this case, it was about improving hospital to home transitions. As I mentioned before, it was informed by a plain language citizen brief that brings together what is known from research evidence about the problem, potential solutions, and implementation considerations. And the panel was facilitated, and the purpose was to uncover some of the unique understanding about the issue and also spark insights about viable solutions that are aligned with the citizens' values and preferences. So in terms of the panel itself, so we had 12 participants, and I think it's a good number. We usually aim for anywhere between 14 and 15 panelists. In the case of a group of individuals of older adults with complex health and social needs, and also caregivers who are taking care of older adults with complex health and social needs, I think it was very, very satisfying to have this number of participants. They came from all across Ontario, so not just from the GTA. So we had the people from more urban areas, but also more rural and remote areas. Most of them were 65 and older, but a few were within their age range of 45 to 64. Predominantly a group of women. And also what's interesting is that 7 out of 8 older adults indicated that they had complex needs, both social and health needs. And the caregivers of older adults with complex, those were caregivers of older adults with complex needs. There were 3 out of 4 of those caregivers. And all the participants were recruited based on explicit criteria from a market research firm asking Canadians. So if you're interested to learn more about the citizen brief, here's a quick overview. It's a short document that presents the context for the deliberation, the problem, or at least the way we understand the problem, 3 elements to address the problem. In this case, we propose different strategies grouped into 3 strategies. One was to enable older adults and their caregivers to play a role in their own care during hospital to home transitions. The second strategies were aiming to enable providers to improve the quality of hospital to home transitions. And lastly, at the decision maker or policymaker level, we wanted to enable them to make small yet rapid change to improve the quality of hospital to home transitions. And lastly, the report presented some potential barriers and windows of opportunity that could facilitate or make the implementation of these options either easier or more difficult. So that's for the process. I'll then turn to Carrie to start sharing some of the 10 insights that we gathered from the citizen deliberations. So Carrie?
Great, thanks, FP. So the first insight was the fact that even though a lot of the participants talked about some positive experiences they had related to hospital home transitions, in general, they did describe them as being both stressful and risky. Next slide. So in the deliberations, in talking about this issue in particular, the panelists identified 6 factors that they thought would help to reduce the level of stress that they were feeling and the risks that were associated with hospital to home transitions. So first was having a provider assigned to them at the point of transition. So this was an individual who knew both the hospital system and the community system, and a person that would be able to link them effectively to support once they were transitioned back home. Second was having access to information. So this included detailed information about their discharge plan, what to expect, as well as how to maintain their own health once they got home. So they needed to, for example, would they need to think about transportation and whether that would be an issue for them, or whether they might need some adaptations to the house in order to live there safely. A third factor was having a comprehensive assessment before being discharged and then again once they went home. And this was really to understand the individual's strengths and what they were able to build on, as well as their needs. And this information could help then tailor the types of supports that would need to be put in place in order for the individual to be maintained in their home successfully. A fourth factor was being meaningfully engaged. And this included being engaged in during the whole process of planning the transition home. So including giving the individual and their family time to understand what the plan was and to think about questions that they might have and other considerations that they might need to think about in order for that transition to occur successfully. A fifth factor was receiving timely follow-up. So we know that many times individuals, once they're discharged home from hospital, they often do not see their family physicians for quite some time. So there was an identified need to have good communication between the hospital and the community, including primary care, about the individual being transitioned home from hospital. And then ensuring that the supports that were going to be needed would be put in place quickly and not be delayed so that the individual may be at risk for either deteriorating or to having to go back to hospital because the supports they needed weren't available. And the final factor related to being in what they called the right silo. There was a sense from the panelists that there were different experiences of care depending on which program someone might have been referred to upon discharge from hospital. And so some of the silos were seen as providing better supports. So I think, trying to link the needs of the individual to the programs and ensuring that the connection with those programs are timely is something that the participants identified as being beneficial. Next slide, please. So the second insight coming from this initiative was that hospital to home transitions and that process was often fueled by assumptions. Next slide. So some of the assumptions or perhaps unrealistic expectations were that older adults who are discharged home will have the support they need when they get home. So there was an assumption that the family members and or friends would be available to provide the type and the amount of support that was needed. Related to this was the idea that for some older adults, they may not be as forthcoming about the level of support that they have at home. And there could be a variety of reasons for that, and including that, often there's a strong desire to leave hospital. People want to go home and to stay at home. And so if they maybe are lacking in some of the supports, they may not be as forthcoming about sharing that in order to ensure that they're able to get home sooner. Another assumption had to do with the care plan, and that an assumption that it would be implemented once the person was back home. So the idea that everybody would be doing everything that they were supposed to do, and we just know that that's not always the case. Another assumption was that there would be someone that would be available to help coordinate the plan and to ensure that all aspects of the plan were being implemented. Another assumption was that all older adults are able to make their own decisions regarding their health and their care. We know that, as Maureen had mentioned, the complexity of the individuals, both in terms of their physical health and in terms of their mental health, it may make that ability to participate in decision making a little bit more challenging. And so we can't assume that people aren't able to make decisions about their care, but we also can't assume that they are able to make those decisions. So we really need to look at people on an individual level. And then finally, there's an assumption that the information that's provided either by the hospital or when individuals return to the community, that information and any instructions are provided in a way that is understandable to older adults and caregivers. So we need to think about how that information is presented. Third insight is that care and decision needs are hard to both identify and address. Next slide. So we know that when individuals are in hospital, or any of us are in hospital, it can be both physically and mentally overwhelming. And because of this, it may be difficult for people to understand and think about what their needs are and what they might need to have in place in order to remain at home successfully. So we need to be thinking about this and finding ways to support individuals to really help in participating in their planning of their care. We know that individuals are rarely engaged in that shared decision making, and it's essential to engage them and empower them, that they are the ones that really understand their needs and their particular situations, and we need to find ways to better to work with them as partners in helping to facilitate a successful transition back home. Next slide. I think this is over to Rebecca.
Great, thanks, Carrie. So the next insight that was gained from the panel was that although panelists were aware of some of the large-scale reforms, and they had sort of varying levels of information about the reforms that were underway in the Ontario health system, there was in general some skepticism about what these reforms might look like. Next slide, please. So the skepticism was fueled by three factors. Overall, there was some mistrust of government reforms and whether they were going to achieve the intended aims. There was difficulty being able to visualize how the silos in the healthcare system might come together. But it wasn't only about the silos in the healthcare system, but recognizing that there was sort of a cross-sectoral approach, so understanding the different sectors in health, understanding the connection of the healthcare sector with social systems, and also thinking about the implications in terms of different levels of government and how coordinated those approaches would be and whether those silos could actually be integrated together. And there was also a recognition that sort of the recognition of Canada being the land of pilots, of pilot projects, and that there was limited capacity to successfully scale up and spread innovative models of care, thinking about transitional care because of scarce resource availability. So because there was limited funding to support some of these initiatives, then could they truly be implemented across the border, across the province? Next slide, please. So insight number 5, from the panelists' perspectives, the older adults and caregivers want to have access to information about comprehensive assessments, including information about illness trajectories. So, next slide, please. So, people wanted personal information to think about their own illness trajectory. If someone's condition was likely to deteriorate, what might that look like? And how can older adults and their families help to anticipate the care needs as that trajectory continues? So, and a specific example that came up was a lack of information about the trajectories of cognitive decline for older adults experiencing Alzheimer's disease. So it makes it really hard to make those informed decisions. Carrie was just talking about, being engaged in decisions and decision making, but people not having enough information to make truly informed decisions. And the other information needs relate to the health and social care system. So thinking about how, what supports are available, what are available publicly, what are available, through additional, private funds. If people have those types of resources, how might they go about accessing them? So they want to know this kind of information, and that's important also for planning. So, we know that many people want to, return home from the hospital and stay at home, but they also need to know what supports will be available through the public healthcare system to actually help them to enact that process or to achieve that goal. Next slide, please. So the other thing that older adults and caregivers, the panelists identified that people want concrete tools to hold providers accountable. So for example, people would like to know, what does this, so in discharge planning, what will the discharge plan look like? What needs to be in place? And what can happen, if things don't go as planned, who's accountable for it? What are the mechanisms and who can they reach out to if things don't go as planned? So, there's a plan in place at discharge, they get home, and if they don't hear from the providers that they're expecting to, to come into the home to support them or to assess them, or if there's a delay for any reason, who do they reach out to actually identify that their care needs are unmet? So they expect that the transition plan is laid out, and they want to know where to go if it doesn't follow that. Next slide, please. So insight number 7, the panelists identified that for providers to actually, so healthcare system providers to be able to offer this kind of support for older adults and their family members or their caregivers, they need time. And they recognize that there was a lack of support, that the system's stretched and busy and there are limited resources, but there needed to be a way to create space and time for providers to engage in this kind of discussion so that people are actually feeling supported, feeling informed, and feeling engaged in decision making. And there was a recognition of a need for tailored approaches, that each individual and family would have different informational and different decision needs that would need to be met, that it really called for a person and family-centered approach that's tailored to the individual to ensure that for that particular individual and their context surrounding them, that things are in place appropriately. And I'm going to turn it over to Maureen now.
Thanks, Rebecca. So the next insight that was identified by the panel is the need to support providers to provide both in-reach and outreach services as opposed to responding reactively. Next slide, please. So the panelists emphasized the need for providers to proactively provide health promotion, prevention, and maintenance support rather than receiving care and support and providing care and support reactively. And the research suggests that proactive support is essential for this population who have complex health and social needs and may not be able to proactively seek care on their own for a number of reasons, such as social isolation, lack of social support, lack of transportation, or other barriers that prevent them from accessing care. So as a result, the recommendation was that providers should be proactive in offering in-reach and outreach services to this vulnerable population. In-reach services are those that are provided proactively to promote health, prevent disease, and help people to live well with all of their chronic conditions. And this is done whenever they are seen or touched by the healthcare system. And this would be, for example, during a regular appointment, for example, that opportunity could be taken to really promote health and prevent illness, not only for older adults, but also for their caregivers who often are not addressed by the healthcare system. And the second is outreach services, where there's a mechanism in place, for example, through primary care, to reach out proactively and connect with those older adults and their caregivers who haven't been seeking help now or in the past, or haven't been seen at all for some time. Next slide. So the next insight identified by the panel was the need to enable decision makers at all levels with a strategy to scale up an innovative hospital-to-home transitional model. And this relates to an approach that's called rapid health learning systems. And the idea is that decision makers would be able to make small but rapid changes to improve the quality of hospital-to-home transitions for older adults with complex health and social needs. And these decision makers would be at all levels, so they would include those working within local organizations delivering care and those working in the government who could try new approaches and then rapidly evaluate them in real time and then quickly adjust the approach when necessary. The panelists hope that innovative models of hospital-to-home transitions that have been shown to be effective through the research could be adopted more rapidly across the province to improve the quality of hospital-to-home transitions. And we know that there are regional inequities, and that to address those and to further support adoption of these models, the panelists suggested that a central provincial body be developed to support implementation of these models of transitional care across the province. And this central body would consist of individuals who are not only trained in the delivery of the model of care, but can also facilitate changes in practice within local regions across Ontario. The next thing that they said was, in order to support a rapid learning system, there's a need for greater openness in sharing successes and failures. So it's not all about sharing successes about best practices, but also it's important to share insights when implementation of an intervention or a transitional care model was less than optimal or failed. Sometimes this lack of transparency on the part of decision makers is due to a fear of failure and their concerns about public or media scrutiny. And finally, there is a need for accountability in a number of ways. First, those who are accountable or responsible to bring about changes in practice, changes in care delivery in terms of transitional care, should have the necessary authority to make the change happen. There needs to be clear communication mechanisms in place to inform the public about the changes and then to monitor the progress. And finally, we need to have a clear set of indicators to monitor the progress. For example, things like monitoring the impact of new models of transitional care on hospital readmission rates, or more importantly, on patient and caregivers' experience or providers' experience. Next slide. And the final insight was that patients, families, and caregivers want to facilitate and they want to be involved in and or trigger system-wide collaboration. Next slide. So in discussing potential strategies to move forward, the panelists really emphasized the need to create a dialogue, and this is what FP was talking about earlier as sort of the next step with this in terms of this work. And this dialogue will involve provider organizations, both from the public sector and the not-for-profit and private sector, government policymakers from all relevant sectors, and most importantly, representatives of older adults with complex needs and caregivers. And it's clear from the literature that to promote a rapid health learning system, we need to ensure that the needs and priorities of patients and caregivers are included and heard and integrated into the strategy. So this dialogue, which we are planning in the future, will help to proactively address some of the challenges that we've already discussed with respect to transitioning from hospital to home and moving forward with scaling up effective models of care, establishing a common vision and priorities, and bridging some of those silos that we see in our healthcare system, and overall finding a solution to this collective solution to this very complex problem. So now I'll turn it over to FP and Stephen.
Thank you, Maureen. Thank you, Rebecca and Carrie. This is great. Thanks for sharing the insights from the citizen panel. Now we'd like to turn to the group and let you share your own insights, perhaps about hospital-to-home transitions, or also indicate which insights resonated with you the most from the ones we listed. So while you gather your thoughts, you can use the chat box to either provide your comments or your questions. The chat box will be monitored by Stephen, so if anything comes up, during in the chat box. We'll bring it up to the attention of the group. In the meantime, I'd like to turn to one of our colleagues, Gail, who is on the landline right now. Stephen, can you unmute Gail? Gail is one of our patient partners. She was a co-investigator on many studies, including the CAS study, and also one of the steering committee member for the citizen panel. So Gail, would you like to add anything in terms of your own insights regarding the findings from the citizen panel and your own experience as a caregiver experiencing many transitions?
Well, I guess I would say that the thing that it resonates most with me is involving the patient or the patient and the caregiver in decision making. That seems to be really, I think, really crucial. The caregiver, I think, needs to be involved at all levels for information right from the beginning of a transition from hospital to home, because often the caregiver is the one that I think has greater insight sometimes than the patient themselves, especially if the patient has multiple issues, and the caregiver can add to all of that, add information and support to the whole team before the patient comes back home.
Perfect. Thank you, Gail. Thank you so much for those insights. So again, if you'd like to use the chat box to provide your feedback and comment, I see someone just wrote in the chat box, do you have any ideas as to why patients may not be forthcoming about support available back home? I don't know if Carrie, Maureen, Rebecca, or perhaps Gail would like to jump on this. Carrie, maybe?
Sure, I can start, and then others can jump in. I think that there could be a lot of reasons. One could be that maybe there isn't really any support at home. And so there could be some embarrassment potentially, like if you're saying that you don't have any family who are available, or maybe you don't have any friends that are available to support you. So there could be that aspect. And as I mentioned earlier, it may also be a real desire to go home. And so because of that, maybe you have a few supports, but maybe not as much as you might need, but you just want to get home. We heard that quite a bit, I know in our CAS study, that was a very motivating factor, people wanting to get home. And so they may say anything in order to get home. So those are a couple of reasons I could think of. I don't know if others have some other thoughts.
Yeah, it's Rebecca. I just want to add, I think sometimes people may have, a family or friend who, they might say, I have people who support me, and they really may support them, but they may not meet all of their support needs. So you might have someone who meets your emotional support needs, but isn't able to provide you with instrumental or tangible support. So people really need to have, a variety of support. So some people may receive instrumental support, so task-oriented supports, but recognizing that we're talking about people with mental health concerns, they may have depressive symptoms that they may not be forthcoming about, or they may not feel comfortable sharing with some individuals, and so they may not have their emotional support needs being met. So it may be that they do have some support, but not all of their needs are met, and yet the system may have assumptions around the different types of supports that may be in place. They may have someone that they talk to regularly on the phone, but they live in another city and can't provide some of the day-to-day instrumental support that someone may need.
And maybe I'll just jump in again. It's Carrie. Just building on what Rebecca said, the question from the provider, the hospital provider side might be, do you have somebody at home to help you? And the answer could be yes, but as Rebecca has outlined, they might be yes in this area, but not in these other areas. So it may be probing more about, again, working with the person and their caregiver, if there is one, about the needs, and then what is going to be required once they get home, and trying to ensure that all of those different requirements or needs are met.
Perfect.
It's Gail. Do you think also that perhaps the patient doesn't really know for sure what is involved and what kinds of care that they could have? So there's a kind of a disconnect between what programs are available and what their needs are, and trying to make that match, and they may be unsure of what's available.
Yeah, absolutely,
yeah.
Gail. Yeah, sorry, go ahead.
No, I was just going to say, Gail, I think that's absolutely true, that mismatch between people's needs and the services that are available is really important. But I was also thinking that oftentimes people lack awareness of what their needs will be because they don't know what to expect when they get home, or they have unrealistic expectations because they don't have enough information about what to expect at home. So that could also be playing into this as well.
Perfect. We do have a few comments and questions on the Q&A. So first we have Jade, and we also have Fran who has a comment, but let's start with Jade, who said that I think the emphasis on developing patient and caregiver evaluation metrics resonated with me. Do you have any insight into what measures could be used?
It's Maureen. I think one of the most important measures is a measure of patient experience. We know from the literature that oftentimes people with multimorbidity that are exposed to these interventions may not necessarily be an improvement, a tangible improvement in quality of life, but there might be an improvement in their experience, which is really separate from their health outcomes. So I think that's really important, but I guess it depends on what perspective you're taking. If you're a patient or a provider, I would hope, and a decision maker, that patient experience would be primary. But certainly cost is another factor, another measure that is important, and that's directly related, for example, to use of hospital readmissions as a way of measuring the effectiveness of an intervention or a new model of care delivery. So that would also be important because we know that this population are frequent users of the healthcare system, but in particular hospital. And so if we can move that needle a little bit, we can certainly see an improvement in cost.
Yeah. It's Carrie. I'll just jump in as well and build on something Maureen was saying earlier. I think working with patients and caregivers to identify what are the most important things we should be asking and evaluating, that's really the key thing. Because, we will only know about our own experience if we happen to be in hospital. But if you're an older adult and you're living with multiple chronic conditions and depressive symptoms, it's most important to hear from those individuals about, what are the things that we want to know about and understand, and to see where there might be differences.
It's Gail. I think we can't predict that as a caregiver or a patient until we're actually in the situation. And so I love the idea of contacting the caregiver and the patient once they're home to find out what works, what doesn't work, and what things do they feel that they need at this point. And that would help to build the whole system so that right from the beginning, getting that information would help for the whole transition right from the beginning.
And I would just build on that, Gail, because I was thinking along the same line. So it's Rebecca here speaking. And I was thinking about that piece of not just assessing at the hospital, but assessing at home, because people may feel, it may not be that they're not disclosing, whether they have the supports in place or what that picture is going to look like at home. But once they're out of that hospital environment, they may realize there were things that they hadn't even known that they would need, and that when they get home, then they realize, I'm home and I'm feeling really lousy. I thought I had the support, but it's not maybe coming through in the way that I thought, or I need different support. So I think that reassessment is really a key piece as people realize, what does this picture actually look like, and how well am I managing? If they're able to have insight into that, people have varying levels of insight.
Excellent, Rebecca. Thanks.
We have an additional comment in the chat box regarding the tools, the concrete tools to monitor and the hospital to home transition. is that because those tools do not exist, or is it because they were not aware of, or as the healthcare providers were not able to properly orient them towards these types of concrete tools? So from my experience with the citizen panels, none of the participants were quite familiar with any concrete tools, and they were not oriented towards such tools to monitor the transition process. Actually, one very clever panelist who was a school teacher, she put together her own monitoring tools to see and do a very comprehensive checklist to document everything that was supposed to happen. And when she mentioned that tool, everybody in the room wanted to have access to her tool to monitor hospital to home transition. But there are some tools being developed, at least to support discussions for hospital to home transitions. I know that HQO just a few months ago put together a conversation tool to discuss and planning the transition process. But I don't know, perhaps Gail, Carrie, Maureen, Rebecca, are you familiar with any other concrete tools that exist? I would take that silence for a no.
That's a no.
Rebecca?
I guess,
no, and what I was going, sorry, go ahead, Gail, please.
I was just going to say that there certainly is a need, but I'm sure, I don't know that there's one that exists. So for sure that would be a need, something to develop, absolutely.
There are some, sorry, go ahead.
Go ahead, Maureen, it's okay.
Yeah. No, I was going to say, I guess it depends on the condition that people are hospitalized for. So as Carrie mentioned earlier, there are some conditions where there are more concrete guidelines for transitional care, like, for example, cardiac patients or orthopedic patients. There are more concrete steps and tools available for those populations transitioning from hospital to home, as opposed to people who are hospitalized for other acute or chronic health problems. So I think it also depends on the reason for hospitalization, because I know there are tools available for some of the specific populations.
Yeah, that's a great point, Maureen, and I think you're right in terms of different conditions. But I also think that for those areas where there aren't those kinds of tools and resources, it really resonated with me when you were talking, FP, about people developing their own tools. And I think, Gail, you've described developing your own tools. So people are noticing that, there's a gap in that the system isn't providing you with those tools. And some people are able to kind of create what works for them and become these sort of de facto care coordinators if there isn't a care coordinator that's in place. But I think that we can do more in the system to provide more support for people so that it's not just, one person creates this here and everyone says that's a fantastic idea, and another person creates something here, and it's resonating because people are identifying that this is a need and a gap. So I think we need to look at those other areas where there aren't those decisional support resources or the transitional care support resources.
And it's Carrie, just jumping in quickly. I think related to that as well is that, when we're talking about multimorbidity, which as Maureen had described is very, very common, having tools that support individual conditions is not always going to be helpful. So how can we develop something that's going to be a little bit more generic in a sense that can be applied to a broad range of circumstances that an individual might be experiencing?
Perfect. Another comment in the chat box, how do we leverage these insights with the changing healthcare landscape? So how can we leverage these? And also, do we see a link between, for instance, staffing ratio and also resources available, such as OT, transitional care assessment, or stroke navigator, and so on? And these resources and the staffing ratio and the quality of the transition. So 2 questions. How do we leverage these? And also any link between staffing ratio and resources?
I was just going to say, I think one way we will be leveraging some of these insights is through the stakeholder dialogue. That will be the next step of this work, where we'll be bringing together policymakers at different levels of decision making, local organizations as well as government, as well as providers and patients and caregivers, to bring these forward and to look at what are the next steps in terms of using these insights to inform practice and policy.
It's Carrie. I think that the other thing is the opportunity that that the new Ontario Health model sort of provides, where there's a real focus on integration, for example. And so, because different communities do have a variety of resources that are out there available in their communities, the key thing is for people to know about them, and particularly providers. So how can we enhance that knowledge and information, and then ensure that there's linkages to be able to leverage those existing resources that are out there to the benefit of the individuals that are transitioning from hospital to home.
Super. Something we'll be discussing on Thursday is with the pandemic we're experiencing is the shift towards virtual care. And we have a comment here about, with the transition to virtual care, is there a greater opportunity to engage caregivers and family?
Mm-hmm. I think I could just respond. I think that's definitely one of the advantages that have been cited with respect to virtual care, is the opportunity to engage both family caregivers and patients. And oftentimes, as you know, family caregivers are not fully engaged in the process, either during the hospital stay or even after hospitalization. And as Gail mentioned, that's a big issue that needs to be looked at, is how to improve that engagement. And so I definitely think that's a benefit of virtual care, assuming people have the resources to access that effectively, access virtual care and use virtual care effectively.
Yeah, I think it's the opportunity and the challenge, right? Because when you're not face-to-face, it can be much more difficult to translate information and to read a person's understanding of that information. And so when we are doing virtual care, that could look a lot of different ways. It could potentially be online, but it could also be over the phone, for example. So there are opportunities for sure to engage more people, but we need to be thoughtful about how we do that, and to find mechanisms to ensure that the information that's being translated is done so in a way that is understandable for people, that, as the panelists had mentioned, provides the time that they need to take in that information and to ask questions. And there's probably a need for multiple follow-ups to ensure that people, have any additional questions answered as they go along through that transition process.
And I'm cautious of the time. I see a few more comments and questions in the chat box. I hope I haven't missed the comment from Fran McMillan. So if we haven't mentioned your comment yet, perhaps you can try to type it in the chat box so that we can share it with the group. One of the comments that we have in the chat box now is that a suggestion to use the centralized informative health hub, which is a very promising initiative, particularly with the same qualified patient staff that was participants to the CAS study, and this could help give updated information in one single place, for example, new viruses, etc. Another comment and question, when a patient is deemed stable to be discharged, but they or their caregiver indicate they cannot manage care needs at home, they are often given no choice but to go home. So what could be done by providers and patients' family members to create some sort of a mutually satisfactory discharge plans?
Well, my first response would be to make sure that my first message to providers would be to make the effort to really fully engage with patients and caregivers to really understand their situation better, and to offer them information and options, and to allow them to identify, better understand what their needs are, we have to let them tell their story. We need to explore potential options, and we need to give people choices.
And we also need to recognize that, you might have two individuals that have, a similar set of physical and mental health circumstances, but, the circumstances at home could be quite different, and the level of support that's required or is available might be very different. So it's hard because, providers need to, really try to understand what is available to individuals when they go home, and to, be willing and able to individualize those discharge plans to accommodate those circumstances where, they really might have very little support. Otherwise, they'll end up back in hospital.
Perfect.
I can't remember it's Gail. I can't remember who had talked about this earlier, but having a coordinator to link what all the resources that are available, and then link those to the patient caregiver needs would, and that to be a kind of a continuation would certainly be helpful. Just the linking of the information.
Super. Thank you, Gail. And something that was mentioned by Sandy, she pointed out there's some work by Health Quality Ontario. So as I mentioned, there's a patient guide to have conversation about discharge planning. But HQ also worked and developed their own quality standards for transitions between home and hospitals. So perhaps the quality standards could be used to evaluate the quality of these transitions. And Sandy also pointed out the PREMs and PROMs that can help to do the evaluation. So the patient-reported outcome measures, PROMs, and also the patient-reported experience measure, PREMs. And I think I have pretty much all the main comments. If there's no more question or comments, thank you so much, everyone. I'm just going to provide you the link to the content for this webinar. So you have the access to the citizen brief and panel summary, which are publicly available via the McMaster Forum website. We also have the CAST study and a lot of other interesting projects. More details available on this website, achru.mcmaster.ca. And also, I want to thank everyone from the steering committee members for the citizen panels, the key informants, and of course, our fantastic panelists who came for this one-day deliberation to share their experiences and ideas to improve hospital-to-home transitions. And I'll extend to you an invitation for meeting us again on Thursday. We'll have another webinar, and this time we'll talk about something, I guess the elephant in the room, COVID-19. So how COVID-19 may have changed the landscape of hospital-to-home transitions. So we'll have this great panel along with also patients and caregivers who have experienced hospital-to-home transitions during the pandemic. So please join us again at noon on Thursday. So thank you very much and have a great day.